Good evening, everyone. First of all, I would like to thank the organizing committee of MEGA Online Course and the MEGA Medical Academy for giving me the chance to be a member of their family today. Thanks to all great speakers, attendees, and panelists. Actually, I saw that the course is very beneficial and fruitful. He giving us lectures from all over the body, all over the world, without moving an inch, while staying at home. I am so proud today to introduce my professor, my talented and famous Professor Samir Ansary. Professor Samir Ansary is a professor in the intensive care medicine at Ain Shams University. Professor Ansary is a great contributor to this course. He is a cornerstone of the success of this course. Today, he will continue his series on nutrition in the ICU in critically ill patients. Our title today, Trace Element in Critically Ill Patients. Dear attendees, prepare your questions and send me back to be answered at the end of the session. Professor Ansary, mic is yours.
Thank you, Dr. Basma, for this nice introduction, really.
Merci.
And today I am going to complete my series of lectures or summary about the nutritional support in the ICU. Today I am going to speak about important item in nutritional support for critical ill patients, which is a trace element in critical illness. And I am going to answer some questions related or regarding trace element administrations for our patients. What is the trace elements and what time I have to start trace element support? And if this trace element must be given for every patient in the ICU or for certain patients, and what is the rule of it and what is the beneficial effect of it? And if there is any interactions between the trace elements administration. Also, we have to know and to be oriented with some side effect of toxic dose or excessive dose of trace element administrations. All of these questions and other questions I have to answer it through this lecture. Supplementation of trace elements in critically ill patients should be considered, especially for extensive burn or for patients suffering from severe trauma, especially in the early time of admission to ICU. Because by time the mitochondria lost its functions and becoming to deteriorate, and so within 48 hours, if we not support these intracellular organelles, we will face some problems in our patient. Trace element really defined as the less than 1 part per million of body weight, very small amount or volume inside the body. And we have some trace element which is macro trace element and measured in milligram, and the other trace elements, micro trace elements, which is measured in microgram. The common or the famous trace elements which we face in ICU: zinc, copper, manganese, selenium, iron, iodine, chromium, and molybdenum. All these are essential for the patient. The micronutrients involve both trace minerals and vitamins, of course. And during our support with nutrition support to the patients, we give the micronutrient to the patient. We must not forget the vitamins and the trace minerals, which include trace minerals, macro minerals like calcium, magnesium, and phosphorus and sulfurs, and also the vitamins and the trace elements which involve the essential and some of the potentially essential trace elements. Micronutrient functions, it has really many functions. Addition, not just nutritional support for the patient, but also it is mandatory and important for the anabolism and for the biochemical reactions inside the body. And most of the trace elements which we give to the patients are cofactors for many enzymes inside the body, or for many enzymes which are involved in metabolism of lipids, proteins, and fats, and carbohydrates. It has a good role and a special role in immunity, especially for both humoral immunity, like immunoglobulin production, and also for cellular immunity through macrophage, neutrophil, and lymphocytes, and so on. Regulation of gene expression on and off, it is acted and facilitated by trace elements. Also, the antioxidant effect, very important and mandatory action of trace elements. It potentiates the action of glutathione peroxidase, potentiates the action of catalase, potentiates the action of superoxide, and so very important in antioxidant defense mechanism for getting rid out of free radicals which are destructive to tissues, which makes the patient stay long time in the ICU, which is predisposing to severe catabolism and long time of persistence of catabolism or persistence of the inflammatory state. Also, it has a role for prevention of chronic disease. And so a trace element, as we will see, very important for critically ill patients. The appropriate route and the dose of the trace elements may be difficult really, and we depend on many measurements, minimum dose and the recommended daily doses, as we will see, and the maximum dose. And in some situations, in severe critical ill patients, sometimes we give the maximum dose to hasten the recovery of the patient as in severe pain. Also, for intervention, it is better to be started early at admission to prevent the progressive inflammatory state. Because any oxidation in the body really predisposing to more tissue destruction, more inflammation and vicious circle, and more cytokine regeneration, and so on. Micronutrient supplementations, mostly in the ICU, we apply it empirically, not dependent on lab investigations, because as we will see, its lab investigation or estimations in the serum and so on may be difficult in some states and may not be available in all the hospitals. Monitoring micronutrient very essential, as we said, because the critical ill patient subjected to some disorders after admissions, especially in absorption. The patient may be becoming edematous, the absorption may be impaired. Some patient may suffering from pernicious anemia, bariatric surgery, inflammatory bowel disease, celiac disease, inflammatory bowel disease. All these impair the absorption of the trace elements, and so may pushing us to support the patient with trace. Some conditions lead to loss of trace elements, like inflammatory bowel disease, fistula, very important in fistula, in oxidates and in severe burn. You find the trace elements, if you measure the serum concentration after burn, you will find it dropping, although the tissue or the oxidates are rich with these trace elements because of shifting of trace element from the blood to the traumatized tissue and to the injured muscles and so on. Some of therapy directly depletes the patients of the micronutrients, such as renal replacement therapy, especially the continuous veno-venous filtration and the continuous veno-venous hemodialysis filtrations, really pushing the more of the trace element to the effluent fluid coming from the machine. For example, the copper we find in traumatized patient and in burn patients, you find it depleted rapidly because of aspirations, because through feces and urine, and most of copper loss in cutaneous, as I said, in cutaneous exudate. Also selenium, after major trauma, we will find it concentrated in the traumatized tissue, and the serum will be low in serum level in selenium. In CRT and continuous renal replacement therapy of renal problem, we will find also depletion of most of trace element. Trace element requirement really, there is too much controversy regarding how to establish the recommended intake. And the questions, we give lower than normal body stores, which may be adaptive and may be sufficient for some patient, or we have to give excessive doses, which may be indicated in severely traumatized and burned patients. Really, there is a gap in our knowledge regarding the basis of nutritional requirement and how much the optimum dose for the patients. And we don't forget the trace element is an inorganic molecules, and so the potentiality for accumulation and toxicity is present, and so we have to avoid excessive doses to avoid the toxic effect of the trace elements. And scientists really must produce new evidence for the optimum doses, which is not settled till now. And so there are many dietary reference intakes for or reference in value for the trace elements. The number one, estimated average requirement, or recommended dietary allowance, which we follow it mostly, and the adequate intake and tolerable upper intake levels, which must be given, as I said, to the most traumatized patient and extensive burn. Assessment of trace element status may depend on static indices. You can check the take sample from blood or tissue or plasma, or you can depend on functional measurements, which will depend on estimation of some enzymes, which these trace element participate in its function. Serum, for example, serum and leukocyte level for zinc, serum and urine levels for copper, serum assay for selenium, and plasma iron and the transferrin and the ferritin level to assess iron store in the body. These are examples of estimation. Static indices really are of limited significance to reflect the accurate trace element status in critical illness. Measuring serum levels of trace element is difficult and require careful collection technique and special tubes for estimating the concentration of the trace element. Previous balance studies have demonstrated the unreliability of serum trace element levels. Serum levels may indicate recently administered trace elements and reflect short-term status, but don't accurately indicate the tissue level. As you know, the traumatized patient or critical ill patient is edematous and the protein loss is too much and the trace element shifted. Maybe the patient suffering from deficit trace element in the tissue, but in the blood may be optimum, and also maybe a trace element migrating to the exudates or through the fistula, and so on. The estimation may be not accurate indicator of trace element stores in our body. Functional measures, we can depend on some enzyme system in which the trace element participate, like leukocyte chemotaxis, like alkaline phosphatase, metalloenzyme, which zinc is participating and very important. Plasma glutathione peroxidase assay for selenium, glutathione oxidase, which is important and mandatory enzyme for getting rid out of oxidative radicals. And so long as the for example, glutathione, if the serum glutathione peroxidase is optimum in its concentrations, you'll be sure the selenium is in adequate amount in the patient body. Lysyl oxidase for copper, zinc protoporphyrin and the heme ratio, and so on. We can depend on the enzyme system. This is an atomic absorption spectrometer block diagram to show us how we measure the trace element in the lab. We depend on a radiation source like xenon lamp or cathode lamp, and this is the sample here, and subjected this sample, put it in a tube, maybe 0.1 mil and so on in the tube, and subjected to different temperatures, and atomization and the wavelengths from atomizations may be calculated and detected through amplifier and signal processor after that. This is a diagrammatic representation of the machine used for trace element estimations in the tissue, in the blood. We can put the sample here in the tube, and this is a tube, small tube, graphite tube for collecting this sample. And we depend on typical setup of atomic either absorption spectrometer or emission spectroscopy for measuring the trace element. Monitoring micronutrient, as I said, it is very important because both hyper and the hypo levels both are deleterious to the patients. Either the low level or the higher level will be harmful for the patient. Interactions between trace elements, there is an interaction here, there is some interactions. You may support patient with zinc or selenium, you will face him suffering from copper deficiency and so on. And even the site of absorption in the GIT depend on the type of the trace elements. The zinc, iron, for example, and selenium are absorbed mainly from duodenum and the jejunum, while the chromium and the copper are absorbed in the ileum. Zinc supplementation decrease copper absorptions and vice versa. And I think we saw some patients nowadays, especially in the COVID epidemic, some patients pushed to take too much zinc and consequently they suffer from copper deficiency. And I will give you a case for this presentation. Iron administration also with intranutritional decreases absorption of copper and zinc and can lead to zinc deficiency. So there is interaction between the different trace elements in either absorption or in action. Altered bioavailability and the requirement of trace element during acute phase response during the early 2-3 days due to flow shift, due to altered regulation of acid-base balance and reduced dietary intake, decreased the absorption, increased the urinary loss, and altered the concentration of transport or binding proteins. And also due to the release of cytokine release or cytokine storm, all these factors really disturb and manipulate the bioavailability or alter the bioavailability of the trace element in our body. Factors which affect the trace element requirement, of course, the geriatric patients need more, malignancy need more of trace elements, hemodialysis, especially continuous replacement therapy, renal replacement therapy, peritoneal dialysis, gastrointestinal loss through surgical fistula and diarrhea, chylus leak and the fistula lead to large volume of protein-rich fluid loss and consequently large trace element loss. Bariatric surgery, parental nutrition in general need support or supplementation of trace element. In contrast to enteral nutrition, rarely we require to support with trace element. This is a trace element, as I said before, it is zinc, copper, selenium, chromium, cobalt, iodine, manganese, and these minerals which we know, calcium, phosphorus, potassium, sodium, and so on. All these are essentials for the body build and for enzyme action. And as I told the start, we have trace element, macro trace elements like iron, zinc, and copper measured in milligram, and the ultra trace element like manganese, cobalt, selenium, chromium, fluoride, and this measured in microgram. And also there are other which toxic trace elements like fluoride, lead, cadmium and mercury, arsenic, lithium, aluminum, and these potentially toxic or toxic trace elements may be contained in some containers, and the patient may subject it, especially if he take some preferred formula from outside. The container itself may contain some of these potential toxic trace elements. We can summarize some of the excessive micronutrient intake or effects of excessive micronutrient intake, like for example, chromium, if increased more than 3 milligram, we will find spinal and joint degeneration and immunity problems. Chromium, as we know, very important in insulin actions, and its lead to insulin resistance. Copper, which is a hematopoietic factor, very important in blood formations. If exceeds 5 milligram, will lead to behavior problems, vascular defect, and infection, anemia, Wilson disease, as we will describe now. Iron will lead, if excessive dose, will lead to vomiting, diarrhea, metabolic acidosis, and hyperglycemia. Manganese may lead, if in toxic doses, to extrapyramidal symptoms. Selenium Also, if toxic dose will decrease the deiodination and will lead to hair and nail discoloration. Zinc, which is very important in immunity, if increased, will lead to decreased immunity on the other side. Vitamin C, if more than 1 gram per day, may lead to renal problems and renal stones and cirrhosis. Vitamin E also may lead to increased mortality, and as we see, for example, vitamin E its dose range from 50 to 800 units of vitamin in diverse populations, and it depends on the patient condition and the extent of injury. Micronutrient monitoring, which must be indicated or must be important in the ICU, especially in some situations. Suppose the patient suffering from burn or TPN, he taking TPN, or subjected to renal replacement therapy, continuous renal replacement therapy, we have to measure selenium specifically. Zinc must be measured in severe burns, trauma, and TPN. Iron and ferritin of the patient suffering from anemia. Copper in the bariatric surgery, very important, and also in burn. Chromium if your patient suffering from insulin resistance and he receiving TPM. Manganese especially for home TPM. Also, don't forget some of the vitamins which are important, like pyridoxines in cases of macrocytic anemia and B12 and cobalamin in macrocytic anemia. Don't forget thiamine in cases of lactic acidosis, cardiac failure, and continued venous hemofiltration. I'm going now to speak about some individual trace elements in summary. A standard trace element formulation with the easiest and most economical means of trace element supplementation, which we use and we depend on it. Some package like multi-trace element for concentrations, multi-trace 5 trace element combinations, trace elements for cobalt plus trace element, and so on. The market is for with this, and Adamel and so on contains some trace elements which are standard package containing more than 1 trace element, and I think this is the easiest and easy method of administration of trace elements in the ICU. Except if you measure depend on lab investigation and you predict how much is the serum level, and you can supplement through individual trace elements, which may be expensive in some situations. Brand name for trace elements which may be available in the markets: Adamel, multitrace 4, multitrace 4 concentrate, multitrace 4 neonatal, multitrace 4 pediatric, multitrace 5 concentrate, and trace elements for pediatric. Available many of the trace element, standard trace element concentration in the market. Adamel, for example, Adamel N may contain chromium, copper, fluoride, iodide, manganese, selenium, molybdenum, zinc, and so on. Multitrace 4 may contain chromium, copper, and manganese, and zinc, and contain aluminum in very, very small amounts, and benzyl alcohol, or maybe aluminum as a contaminant, not dosing adult trace element supplements. This is a summary for doses, how much you must give for your ordinary patient. Chromium from 10 to 15 milligram per day may increase to 20 milligram if there is intestinal fluid loss, and this is indicated chromium especially for diabetic patient and for facilitating the insulin action. Copper may be given from 500 to 1,500 microgram per day. Manganese from 150 to 800 microgram per day. Selenium from 20 up to 40 microgram and even 50 microgram per day. Zinc from 2.5 to 4 milligram per day, and consider increasing the dose to another 2 milligrams instead in catabolic state of the patient suffering from extensive burn. Excretions of the trace elements mostly through the urine and feces and the bile. Chromium excreted through urine and bile, copper through feces, manganese through feces, and mostly all of them are through urine and feces. Trace element and functions is a summary. Immune system, if you want to potentiate the immune system, give copper, zinc, ferrous, and selenium. Energy production, manganese, if you want to increase energy. For hormone system, you have to give iron, manganese, zinc, and copper. For vitamin production, especially vitamin B12, you can give cobalamin. And blood productions, you don't forget copper, very important, hemobiotic trace elements, very important. If it is deficient, the patient will suffering from anemia, and also give iron if the patient suffering from iron deficiency. If your patient suffering from enzyme system problem, zinc, copper, ferrous, and molybdenum. Skeletal system, you can give zinc and manganese. Reproduction, copper, important, and manganese and zinc. This is another summary also, as I said, chromium for glucose metabolism, cobalt for component of vitamin B12, copper cofactor for cytochrome oxidase, fluorine present in bone and teeth, iodine compound of thyroid hormones, important for thyroid hormone production, iron present in heme pigments and on most of the pigments, myoglobin and heme, manganese a cofactor for many enzymes. Chromium, if we speak about individual trace elements, now we start by chromium. Doses we can give from 10 to 15 microgram chromium per day. Very important, its deficiency symptoms lead to glucose intolerance, ataxia, peripheral neuropathy, confusional state similar to mild moderate hepatic encephalopathy. After that, zinc is very important for formation of metalloenzyme like carbonic anhydrase, also for protein metabolism, for RNA conformation, and for membrane stabilization. It is very important for gene expression and gene on and off, enzymatic reactions, especially antioxidant, and immune functions, and for protein synthesis. Wound healing, very important. We give it sometimes in ulcers and in wound to hasten the healing, in growth and development. It is available in meat, seafood, dairy products, nuts, legumes, and whole grains. Contains high amount. Normal serum zinc level range from 70 to 150 microgram per deciliter. Total body zinc about 2 grams. 60% of the zinc in the body is inside the skeletal muscles, 30% in the bone, concentrated also in prostata and the hippocampus area, and so very important for neurological functions. And the recommended daily acquired dose is 10 milligram for adults. Don't forget glucine, which is a protein very important containing zinc and very important for taste sensation. Essential for insulin, for storage of insulin and release from the pancreas, and also essential for vitamin A level in the serum. And I think zinc also, as we know, has some antivirals or hasten the recovery from infection with viral infection. Zinc deficiency lead to a characteristic syndrome or acrodermatitis enteropathica, which is inflammations around the acral area, like the mouth and the tips of the fingers, and also the toes. And so very important to treat it by zinc, such these dermatitis conditions. Zinc deficiency, don't forget, lead to alopecia, decreased sperm and maturation, so important for reproduction, impaired healing of wound, and so very important in treatment of extensive wound and burn, loss of taste activity if there is zinc deficiency, and also it leads to impaired vision if it is deficient, and neuropsychiatric manifestations if we suffering from deficiency. Zinc functions again, it is a constituent and cofactor for more than 300 enzymes, and specifically the metalloenzymes like carbonic anhydrase, alkaline phosphatase, alcohol dehydrogenase, and superoxide dismutase. Zinc is essential for cell growth and for division, and for immune function, and the enzyme reactions, and the DNA synthesis and the protein production. accelerates the wound healing. Zinc is commonly used in hospital as a treatment for burn center, certain ulcers and other skin injury. Zinc play a critical role in collagen synthesis and immune function and inflammatory response. It is necessary for proper healing. In fact, skin holds a relative high amount of about 5% of body zinc content. So zinc is really very important for many items and for many enzyme system, and we can use it in treating some refractory ulcers and also for wound, hastening the wound healing and so on. And so it reduces the inflammatory state. It reduces the persistent inflammatory states which can occur in some critical ill patients. As we know, some patients can suffering from persistent inflammation, or the second stage, the catabolic stage, may be extended for even months. And so zinc, one of the trace elements which hinder or stop this inflammatory state. Zinc is a component of superoxide dismutase. It is very important really in all the antioxidant enzyme in the body, glutathione peroxidase, catalase, superoxide dismutase, very important and impair and hinder the changing of oxygen molecules to oxygen-free radicals. And as we know, oxidative stress leads to chronic inflammation, a contributing factor in a wide array of chronic illness, such as heart disease, cancer, mental decline. All of these diseases, which are long-standing diseases, a patient suffering from some existence of an oxidative state or inflammatory state. Zinc is beneficial in such states. Zinc is largely a protein bound, and so in the critical ill patients, due to loss of protein, it contributes to zinc loss and the deficiency of zinc. It plays a crucial role in cellular growth and replication and rapid epithelialization and wound healing again, and cellular immunity and protection against oxidative stress. Zinc play a key role in maintaining vision and concentrated in the eye, and maybe changes in the retina in patients suffering from zinc deficiency. Also, zinc is a gene expression and very important for working of the gene. Low zinc level can be associated with male infertility, sickle cell disease, major depression, and type 2 diabetes, and taste problems and insomnia, and so on. It appears to lessen the symptoms of rhinovirus, and so it has some antiviral activity. Zinc is essential for neurotransmitters and melatonin formation, and so it plays an important role in melatonin formation and the sleep-awake cycle for the many patients, especially those suffering from insomnia. Zinc deficiency, as I told, lead to skin rash, lead to glucose intolerance, poor wound healing, hepatic dysfunction, diminished work capacity of respiratory muscles, and so on. And so 25 milligrams per day of elemental zinc is usually recommended, especially in wound patient and burns patient. Normal serum zinc again from 70 to 150 microgram per deciliter. Low serum alkaline phosphatase may be used as an indirect measure of zinc deficiency. As I said before, we depend for our analysis for trace element or in general or for estimating the concentration, we can go through the functional evaluation of the enzyme system in which this trace element participate or sharing the function. Excessive prolonged zinc intake may lead to impaired immune function. And so many patients nowadays really consumes too much zinc, and this is very dangerous. And I said one of the main problems, copper deficiency. Additional supplementation is indicated in critically ill patients, as I told, 25 milligram per day or 50 microgram per kg per day for parenteral dose, especially for pediatric. Don't forget some of the zinc compounds contains cadmium, which is very toxic and leads to renal failure, and so we advise to use zinc gluconate products more better and free of cadmium. Especially we see zinc toxicity in welders who inhale zinc oxide from their. The third trace elements copper, which is very essential and mandatory for wound healing, for hematobiosis, formation of red blood cells and bone marrow function, and for platelets formation, and also at the same time it is antioxidant and very important for connective tissue cross-linking. Copper deficiency may develop after excessive treatment with zinc therapy, and the patient suffering from anemia, neutropenia, and leukopenia, because as I said, copper is very essential for hematobiotic functions in the bone marrow. This is a case of copper deficiency, myeloneuropathy, and pancytopenia secondary to overuse of zinc supplementations. The patient, in summary, is 53 years old. He takes excessive doses of zinc, and after that, he made suffering from sensory and motor neuropathy in the lower limb and decreased vibration and proprioception sense. And the hemoglobin dropped. He is anemic, a mean corpuscular volume, white blood cells count 2.6, suffering from leukopenia, but normal vitamin B12, folate, immune functions. Brain and spine MRI show problem of copper deficiency. Serum copper was very low. It is 7 microgram per deciliters, normal from 70 to 150. Serum zinc is high, 2.28 microgram per ml. The normal range from 0.66 to 1.1, or just the patient treated with 2 milligram per day of copper, and he improved to some extent. Copper is very effective and important for connective tissue cross-linking, and this is very important. Copper deficiency led to pancytopenia, myelopathy, or peripheral neuropathy. Copper may lead to hepatic insufficiency, and so we have to decrease copper or even omit it totally if the patient suffering from hepatic problems. And we don't forget Wilson disease, in which there is liver problems due to excessive copper and the deposition of copper in the tissue, including the liver, and which lead to liver dysfunction, neurological disorders, and the Kaiser-Fleischer ring in the cornea. Copper is very important in burned patient. The requirement 5 milligram per day in adult and 20 microgram per kg per day in children are necessary for compensations of cutaneous loss which occur in the oxidation coming from the burned area. This is a summary of Wilson disease, which develops from excessive copper, and those patients are suffering from enzyme deficiency ETB7A, which help or facilitate the combination of copper with ceruloplasmin, and this is an inherited disease, and if the patient suffering from this genetic disease, he will suffering from Wilson disease, from copper deposition in all over the tissue of the body, including liver, brain, and kidney, and so leading to Kaiser-Fleischer ring, liver problems, also CNS disorders like dystonia and dysarthria, and dysphagia and mask-like face, and many problems related to copper. And it treated, as you know, by penicillamine or chelating agents to decrease the copper level. Copper deficiency myeloneuropathy, which is evident here in these pictures. Here, there is problem here, and also in the brainstem. It is a constitute of selenium is a fourth trace element, which is essential for endogenous defense system against the oxidative stress, and this is the most important trace element as antioxidant in the body. Really. Increases selective uptake of selenium by injured tissue for defense against reactive oxygen species may explain the progressive decline in plasma and urinary levels, because selenium is shifted from blood to the injured tissue. And the current recommended daily allowance for selenium is 55 microgram per day. Low plasma value are inversely correlated with severity scores in the ICU. When you see your the plasma value of selenium is low, you suspect the patient is highly in a critical state. Maximization of glutathione peroxidase activity, and so it is very important as antioxidant cofactor for enzymes which work as antioxidant like glutathione. The requirement daily 60 microgram per day of selenium in trauma, 190 microgram per day in burned patient. Supranormal intake may lead to easy fatigue, irritability, neuropathy, and gastrointestinal symptoms. And of course, if your patient is supported by other antioxidant or other anti-free radicals like vitamin E, vitamin C, beta carotene, you will minimize the requirement of selenium as antioxidant defense. Selenium deficiency leads to cardiomyopathy, leading to congestive heart failure and arrhythmia. The other trace element, manganese, which is important in carbohydrate and lipid metabolism, and the manganese serve as a component of superoxide dismutase. Superoxide dismutase, one of the antioxidant enzyme, and is also important for arginine and pyruvate metabolism. Magnesium deficiency lead to carbohydrate and lipid defective carbohydrate and lipid metabolism, and lead to blood clotting defect and hypocholesterolemia and bone problems. Manganese is the enteral intake for about 2 milligrams per day, and while parenteral dose from 60 to 100 microgram per day. Those should be decreased in patients with hepatic insufficiency. Manganese toxicity may lead to nausea, vomiting, headache, disorientation, compulsive laughing, or crying. Iron, as most of us know, it is very important as a cofactor for all energy metabolism, for oxygen transport, hemoglobin and myoglobin, and so on. Iron is a key component of the heme molecule and also other oxygen-carrying proteins, including heme enzyme, myoglobin, and cytochrome A. And as we know, transferrin is a transport protein for iron and binds to 2 iron molecules, transport iron to various organs and tissue. Serum iron plus total iron bound to transferrin give you the total iron concentration or in the circulation. Determination of transferrin give total iron binding capacity. And as the iron contains in green leafy vegetables, grains, pulses, liver, spleen, and meat and seafoods. Iron is a constitute of functional group of enzymes, importance in Krebs cycle, responsible for energy metabolism. Decreased transferrin saturation in patients with major burn may lead to impairment of erythropoietin response, even in patients with normal level of erythropoietin. A decline in the cellular immune response occurs quite early with the onset of hyperinflammation and severe sepsis, and so we have to support the patient early. Also, mitochondrial dysfunctions may become irreversible 48 hours after the onset of severe sepsis, so early admission of trace element is important, and the optimum dose still now for reducing deaths due to oxidative stress is also not yet determined. The patient with increased serum zinc and copper concentration during ICU stay had significantly lower mortality. And some diseases. Glutamine oxidation, very important for survival of human pluripotent stem cells, which is a source of other cells, ectoderm, endoderm, and mesoderm cells. Also, vitamin C is very important for vasopressors. As you know, it is a cofactor important for tyrosine hydroxylase, which converted to dopamine and norepinephrine and epinephrine, and so it is very important also to help to make proteins and decrease. Vitamin C can shorten the duration of the common cold, reduce blood glucose in patient diabetic, lower the blood pressure, open constricted airway, and so it is very important. In critical ill patient, we can go up with a dose up to 4 grams of vitamin C per day. Sometimes we give 1,500 in septic shock, for example. We give vitamin C in addition to thiamine, in addition to hydrocortisone, which potentiate the vasopressors and even hasten the recovery from requirement to vasopressors, and so it is very important. But normal persons need only 0.1 gram daily of vitamin C. But in critically ill patients need high dose of vitamin C, but take care of side effects like renal stones and so on. Vitamin B12, as you know, lead to combined degeneration of deficits, lead to anemia, megakaryocytic anemia. It is important to prevent depression and psychosis, and its deficiency lead to nerve damage and numbness and decreased energy production and so on. Cobalt is also very important in its deficiency, like vitamin B12 lead to same manifestations. And I think we have to stop here. And as you know, trace elements is a long topic. Nutritional support also is a long topic. I try to summarize the nutritional support and the trace element in these few lectures, or 3 lectures or 4 lectures, I don't remember. And if we have time, another time, we can support these lectures with another knowledge of regarding nutrition support. Thank you.
Thank you very much, Prof. Samir, for the very interesting lecture, as usual. And I will leave the mic to the moderator for the questions.
Okay, thank you so much, Professor Samir. It was an interesting and beneficial lecture. We are grateful for your time and the effort you took to share your thoughts and experience with us. Thanks, Professor Samir. And we will start our questions. The first question by Dr. Abdurrahman Yasser. How lack of nutrition can affect the patient rehab and safety in ICU?
Of course, nutrition is very important, as we said in the previous lectures. It is mandatory, and you have to select at first the route of optimum nutritional support for your patient, and you have to consider underfeeding and overfeeding. Both represent malnutritional states, and you have to manage any deficiency in your patients from different ingredients, like either micronutrient or micronutrient, and all the complications you suspect from the nutrition support. Especially, you have to consider the feeding syndrome, for example, is very important to consider. Don't start your full nutritional support in malnourished patient. You have to start gradually, and also avoid hypoglycemia by withdrawing TPN gradually. And so complications, I think we mentioned in the previous lectures, it is many if you not give the optimum dose and the optimum selections of the ingredient.
Okay, thanks, Professor. Second question by Dr. Khalid Radwan. What are the empirical doses to be given to ICU patient for zinc, copper, selenium, or actual measurable values which estimated the recommended given doses?
These are questions which is till now very, very difficult, really, as I mentioned. The optimum dose for your patient, for ordinary patients, and for the critically ill patient, because it differs for both sides, for both patients. Till now not reported or not actually known, but I give, and you can revise the lectures and see there is a range of doses. Suppose your patients, if suffering from severe critical illness or severe trauma or extensive burn, you have to give the higher dose, the higher recommended daily dose. If your patient is an optimum situations or moderate, you can give depend on the average dose. The normal patient may depend on the low dose, may be sufficient. And so the optimum dose till now, you can't assert really. It is a major problem in the ICU. But in general, I mentioned it in my lectures. You can return to the schedule which we put.
Okay. Question number 3 by Dr. Ann. Where we can measure zinc, would you recommend zinc empirically in all patients of ICU? Or we can target a special population like patients with chronic heart failure and burns?
Mostly till now, and the easiest route of administration or easiest method of administration is the empirical administrations through using this standard formula which is available, which contains 4 trace elements or 5 trace elements, and it is the cheapest one which can be used for our patient in the ICU. If your hospital is equipped with spectroscopy and the facility for estimating the concentration of trace element in the blood, on serum, in the tissue, you can depend on it and you can give the accurate amount of requirement.
Okay. Another question by Dr. Asma. Role of glutathione in critically ill patient.
Glutathione peroxidase is a very important antioxidant enzyme in the critical ill patients, like mutilase, like superoxide catalase. It is a very important antioxidant enzyme for in the critically ill patients. It prevents the formations of free radicals like superoxide and hydroxide generated from the other ingredient, especially the oxygen molecules.
Okay. The last question by Dr. Amir Fouad. Different in trace element between enteral and parenteral in critically ill patient.
Mostly in enteral nutritional patients, we are not needing so much trace elements because mostly they receive a natural food which containing the trace element required. But suppose your patient is highly critical or traumatized severely, he needs some support or he needs some supplementations. But in TPN in general, all of the patients need trace element supplementation.
Okay, thanks, Professor Samir. It was interesting and beneficial and fruitful lecture.